Well, welcome back to the Honor Health Medical Center Cardiac Catheterization Laboratory. Pleased to be joining you. Our thoughts and our prayers go out to our colleagues around the country and around the world who are fighting a very noble battle against this current pandemic. This is a patient, we'll introduce the patient. This is a patient, though, that had clear progression of symptoms. First, if we can do a wide angle of our team here, we have a great cath lab team in Jeremy, Colin, and Tracy, veteran cath lab folks. No stranger to our live cases, Bob Riley, Dr. Bob Riley, cardiovascular surgeon. Our new young interventional cardiologist, Pratik Dalal, who just joined us from Michigan. And another person who's no stranger to our live cases, Dr. Robert Burke, our echocardiographer extraordinaire. Can we look at the clinical background? So this is a patient with coronary disease and previous bypass surgery. He had the bypass several decades ago in Ann Arbor, and at that time, evidently they were doing a fair number of lima-remas. You can see his coronary anatomy. He's got a lima to the circ, a rema to the LAD, a vein graft to the diag, a vein graft to the OM. He's had previous PCI of the right coronary because of the vein graft to the right had closed down. You can see by the clinical background slide, he has multiple risk factors for coronary disease, including diabetes. He's had a previous stroke. He's had previous PE, and now he has severe symptomatic aortic stenosis, and the hemodynamic measurements are shown. Go to the next slide. Bob, you vetted this. Bob Burke, you vetted this. Take us through what you found when you looked at this patient.
So what you can see on the 3-Mencio here is that from a sizing standpoint, he's a large valve and would definitely fit for a 34 Evolut Pro Plus. No problems in that regard. The sinus volume is excellent, so no issues there. And the coronary heights, I think next slide. The coronary heights were also wonderful. Now, he's dealing with bypass grafts anyway, so it's less of an issue, but specifically for the right coronary, which he's still working off of, again, we shouldn't have any issues with access down the road, so really should not be a problem.
Okay, what about the multiplanar view?
So you can see here in the multiplane or hockey puck view that the calcification is really all leaflet. There's no significant annular calcification. Again, nothing to worry about as far as setting us up for significant PVL as a primary concern.
Okay, and this view, anything different to add?
Again, this really does show that you don't see any spikes going down into the annulus or into the LVOT. There's nothing down onto the aortomitral curtain. So those things that we would typically look out for as setups for PVL, we don't see them right now.
Why don't you go show us what you've been doing with some of the Siemens software while we were doing the setup. While you're walking over there, Bob Riley, you guys have got everything lined up. Maybe we could go to the fluoro image. Bob, tell us what you've done right now.
So up to this point in preparation, we've gained access for our pigtail in the right radial. We generally use radial instead of bilateral groin access so that we can avoid the complication of the non-large sheath. Unfortunately, right now we actually have crossed, while we're waiting, crossed into the ventricle with our pigtail, so we have to reposition that on camera here. But right radial access for our pigtail, and we have left groin access for our large sheath. We pre-dilated with a Cook sheath, and then you use an inline technique here, and our valve is sitting in the mid-abdominal aorta, ready to cross the arch.
So, and I notice, once again, like the last case, you use the Manta biochemical vascular closure device for large bore. We're doing a lot more of that than the Perclose these days.
Yes, and in particular, this case, there's really not a great calcium-free segment. We found a small portion where we can access without calcium, but we're very concerned that we would have a hard time getting pre-closure devices to stick.
So Manta might be a really good design for these types of heavily calcified peripheral vessels.
In our experience, it has been, and that's one reason we have confidence doing this way.
Okay, so Pratik Dalal, our new young interventionalist, dealer's choice on whether we did a 29S3 or a core valve. What was your thinking?
Yeah, so I think that either valve would have sufficed here. I believe that with the new inline platform here, a 34 Pro Plus is an excellent choice, specifically when you don't have to worry about re-engaging major arteries here. in the
Perfect,
future.
perfect. While you guys do your work, Bob, maybe we can go to TEE and you can tell us what measurements you were making with your toys over there.
Okay, so over here, this is the baseline evaluation. Now, as you recall, he did undergo a valvuloplasty previously, so he's had a definite improvement, but certainly not cure for his aortic stenosis. His mean gradient was 26, and his calculated valve area was 1.2 centimeters squared. As we go through, we routinely do 3D imaging on these patients and then deal with the software that Siemens has to help us model the aortic valve. And basically, it's confirmation of what we've seen on the 3-Mensio or the CT imaging. In this situation, we went and got a volume of the aortic root and the valve itself, and this ends up giving us a perimeter of 89 millimeter, which is just about exactly what we had on CT. Again, fitting very nicely for a 34 millimeter Evolut Pro Plus.
Bob, you do a lot of this modeling with the Siemens software, and I know you find this very helpful. We do a lot of TEE imaging, and you're able to really give us a ton of adjunctive information in these cases.
Yeah, it's excellent software, and we can even confirm the ejection fraction in these cases. Again, this is an actual volume of the left ventricle. We have an EF of 54%. So this helps us with planning and being certain with our valve sizing. Now, sometimes we have issues with CT, with motion artifact or difficulties with contrast. So we have used this software on multiple occasions to actually size the aortic valve as a way to minimize contrast exposure.
Bob, let's go live to Fleur. That's great, Bob. Thank you very much. Bob Riley, you want to tell us where you're at now?
So we have a small non-coronary cusp with a tri-leaflet valve, and pigtail keeps jumping into the right coronary cusp, but we wanted to use a alternate approach or alternate view where we overlap the left and the right cusps here.
Okay.
So our alternate view here is LAO 28, cranial 18. Our original coplanar view is what, Jeremy? LAO 17, crani 17.
Yeah, okay. So this is a nice little trick that you're using. That's great. So so I agree with CoreValve on this, and I think the fact that there are a few complexities to this, and I think having the Pro Plus mulligan, if you will, you can recapture this if you don't like it. And we've had a really great experience with the Evolut Pro Plus. Bob, might you discuss vascular access and the fact that you can take on complex peripheral anatomy, peripheral vascular anatomy?
So with the low profile access using an inline technique, we're really able to get about 98% of our cases done transfemorally and not have to use alternative access. So the inline technique has really facilitated the availability of this device to a wide range of patients.
Well, I love what you're doing so far. I love the simplicity, yet the measured fashion with how you guys have proceeded. Why don't we drop a valve in here?
Okay.
Why don't you, Bob, talk through what you're doing, and Pratik, you add to his commentary.
So we're crossing the native valve here. I expect we're going to displace our pigtail. We did a little bit, so let me reposition that as best I can.
And the thing that we noticed about this patient, he's already had a pacemaker, so that does play a role into having freedom to implant maybe
Show me
a
where
little
we are.
deeper as needed.
Inject there. So now our ring is at the annular plane. We do have still some parallax in here, so I think we probably want to go a little bit more LAO. Okay. Pratik, what do you want to do here?
I think using the alternative view to deploy this valve often leads to a shallower implant, and I think that's always ideal here with core valves. So my preference here would go to the secondary view or the RAO view here to get a more shallow deployment.
I like that. I like that.
So Jeremy, can you come to the RAO view?
So young and yet so mature in his decision making. This is great. I like that.
And here we can see that almost all the parallax here is taken out of the valve as well. So I think we can
Start here.
take a squirt and
All right.
just give a little
So we're
puff here.
trying to be, in this particular case, we're trying to be minimalist in the contrast exposure. Another reason why transesophageal echocardiography provides for us some information that we would ordinarily perhaps need more contrast injections to obtain. He's got a reduced GFR, somewhat elevated creatinine, so a minimalist view it would be really good in terms of our contrast injections.
While we're doing this, Dr. Schwartzstein, if you can just pace us at 110 to 120, reduce the motion a little bit of the annulus.
Bob, I know that you tend to go to pacing pretty early on in most of these cases, rather than frustrate yourself and whatnot with the multiple deployments. You tend to pace early. Is that correct?
Yeah, just enough to get a little excited with your heart rate, like Dr. Reardon says.
Yeah.
Not so much to create hypotension, just to get a little excitement.
Exactly.
Get the blood flowing.
Like the first time you saw your wife, right?
Correct.
Okay, good. That's what Reardon actually says. Okay.
Looks like it came out, huh?
Did we
Okay.
jump it above the annulus?
Yeah.
Yep.
You're about
So why don't we recapture here and let's just take our time and get our pigtail back in the position we want. Bob, how much forward pressure are you putting on that?
Right now, none. Our pigtail's wrapped a little bit. A lot of it.
This pressure's a little bit on the lower side
All
here.
right, gonna come out of the annulus then.
Yeah.
No.
No, we're gonna take
Coming
it out
back.
of the annulus.
Why don't you bring the pacemaker down? Why don't you take him off pacemaker? Let him breathe a little bit.
Go live.
Still wrapped there, huh?
There we go. Still, no, there you go. You're free. Test. Yep.
Not the right cusp.
We're in the right-left overlap,
Or
right?
maybe it is the
You-
right- the
You're in the
correct
right
cusp,
cusp. You
yeah.
are. Want to take a pic here?
Yeah.
Let's take a picture. Inject. Oh yeah, so we have to get on the other one.
Go live. No, that was the right. That's in the right
that's the
cusp.
right.
Yeah.
That's where you want to be?
Not usually.
Yeah. We can leave it there. It doesn't.
Don't come back too far because you're going to be back pushing into the descending.
Wow.
Can I have a little feel? I have
Yeah.
a feel. Do you mind?
I don't know if I need an angled pig or what, but from the get-go, it's always
It's
angled
been
that
a
direction.
little bit funky that way. Test that for me. Let me
It's
see
in
how
the
far
right
off the.
cusp. Yeah.
Okay, now.
So here we are in the RAO view, or alternative angle view, so that there's overlap. So we're going to let the valve open a little bit to flower, and then we're going to start pacing a little rapidly to drop our cardiac output. So let's slow down here and have Dr. Schwartzstein turn the pacer on at 100. We may end up going to 150 if we still need less cardiac output. Go to 120. Oh.
Forward tension.
All right, with forward tension, we're going to go rapid release now.
Yep.
That's good. Like that.
Okay, now we're going to come back a little bit more. And let's slow our pacemaker down.
Give me a test there, please. Nice. And so, Bob, we really have the luxury of being a little deeper, as we've said, because of the presence already of a permanent pacemaker. Bob Burke, do you want to take a look at this and tell us what you're seeing by TEE?
Yep.
Given everything, I like the depth of your implant at this point.
So we did get a little wide in QRS with this depth. But like you said, we have a permanent pacemaker.
Still not looking terribly deep, so, you know. Still have a little bit of PVL there. Again, this hasn't been in for more than a couple of seconds, so.
I would say if we don't like this, we go back to the original implant view and then just take a little parallax off and try it that way. Because this, like you said, tends to
Make it shallow.
promote shallow deployment. So go back to the original implant view here. And let's do a Cine injection here when he gets there. For depth purposes, see if our echo and our Cine are correlate.
Deep.
You know, objectively, your PVL is trivial to mild right now, but, you know, it's just a matter of trying to get perfect if that's what we're going to get. We're going to look deep on the right side, and we're going to be shallow on the non, is what we're dealing with. I also think that when we end up releasing, this is going to shift, and it's going to favor coming up on the right, and it should drop even further on the non because of that septal bulge that we're dealing with.
Ready? Take a
Do
picture.
we like the depth?
Yeah, let's take a picture here, shall we? Inject. And so, Bob, your feeling is it's going to come up on the non?
It's going to drop on the non, it'll come up on the right because of the way the septal bulge is there.
Oh, I see.
And
yeah.
we're not laying over at all. We can't lay over with the way that the device is
moving around.
oriented right
Okay,
now.
just
I pulled it.
Okay. I wondered about that. Flora?
Okay.
The rapid pace on pull, right?
On deployment. Yeah.
So what we're going to do now is, Bob, why don't you discuss pacing on release?
Well, Dr. Dalal had the idea. I agree that in this particular case, we are going to utilize rapid pacing. We don't want the valve to move due to a PVC or anything else. So we're going to rapidly pace to get our cardiac output to 0 when we release this valve. So it's only the tensile strength of the stent frame that's interacting.
And Bob Burke, some of your observations on echo. What do you anticipate when we release this valve that it's going to do on the non in terms of movement and on the other cusps?
So if anything, this is probably going to drop down a little bit on the non. It may come up a little bit on the right, which would actually favor getting this into more collinear orientation with the aortic root.
Okay.
Okay, so we're ready to do that. So we're going to pull back our wire so there's no wire pushing the valve. And we're going to turn our pacer on to 180.
Boy, Bob, to your point, we had a couple of PVCs there, which really does reinforce why we're pacing here.
Yeah. All right, you ready to deploy? All right, let's go ahead and do that now. Rapid pace.
Hold a little forward pressure.
And I'm going to have a little forward pressure as we do it. Okay, no cardiac output. Okay, turn the pacer down. Push wire in.
Now let's be real careful
Hold on a
not to
second. I'm
interact
gonna
that
pull
nose
back.
cone.
Leave the wire across
There
in
you
case
go.
we have any dislodgement.
So
Perfect.
that looks perfect. Now, and this is the point where
Okay, stop here. Unmag, show us the AP shot.
this is the point where the cath lab knows, you know, if we have to do any manipulation or moving of this
Keep the
valve,
wire in and close up here.
that we have snares and whatnot ready. But I thought that was a
Yep.
picture-perfect method of getting that release. That's
ready.
perfect. Bob Burke, what are you seeing?
Get the sheath ready.
Might have some trivial leak right there, but really nothing to write home about right now, which is great.
And how do you like our depth, at least on echo?
Depth looks good.
Okay, let's leave the wire across the ventricle, put our sheath in, and then we'll pull our our curled wire, preformed wire over an end hole catheter.
So, Bob Riley, this is clearly a case where some of the peculiarities of his anatomy, including the septal bulge, required, different technique, different maneuvers, not just taking the first depth of implant we had, but rather where the experience with this valve comes in. Most of these cases are very quick and very easy, but he had some complexities and peculiarities to his anatomy that required a little bit more sophisticated maneuvering.
Right, and that also includes what we're about ready to do now, which is put our Cook catheter back in and then pull this preformed wire over an end hole catheter so that we straighten it out and don't run the risk of catching this coil on the device itself.
So what we do in general when we do this is we can use any end hole catheter. I like a multi A1 because that really does straighten out the tip of this the best. We have a multi-purpose A1. Let's get a multi A1 on the table, and so we'll cross the valve complex with that, straighten out the preformed wire, and then pull it back as a unit. And Bob Burke, you're pretty happy with what you're seeing, correct?
Yeah, right now this looks great. We've got tiny jet right there. Again, nothing to really write home about.
We do have that wire still in. You might see some wire leak too.
Bob, if you could quantify the leak, I think we're in the trivial range, are we not?
Yeah, this is trivial. There's nothing to write home about. This is excellent across the board.
And then, Bob, what do you gain eventually when you go into the transgastric view, which I know you're itching to do? What do you gain when you further interrogate this in that view?
Well, really, this is your honesty shot because you can have shadowing from calcium. You can have a lot of different things that can mislead you and make you feel like you don't have a problem. But when we're in the transgastric view, you've got none of that annular calcification that sometimes blocks regurgitant jets. Again, in this case, we didn't have a lot of annular calcification, so probably not as much of an issue. It was really all leaflet calcification that we were dealing with. And as you can see here, really not a lot of PVL. You've got a tiny little jet there, and that's about the extent of it. So this is looking really good so far.
Boy, I love everything about this. The depth of implant, number one. Number two, what you have in terms of residual PVL. But I also really like the way they managed every aspect of this case. The initial pigtail wasn't seeding into the non-coronary cusp. They exchanged out for an angled pigtail, and that sat in there beautifully. They were willing to do things like rapid pace to bring the pressure down so as to stabilize the movement of the valve. They resituated the valve depth several times, and I think they really have right now a picture-perfect deployment.
I'm going to go to the other side now for the Manta deployment.
So, Bob, I thought they managed this extremely well. Managed what is complex anatomy, but I also think that their ability to manage the complexities of the case was augmented by all of our adjunctive imaging. So what did you find in the end hemodynamically in terms of our echo data?
So hemodynamically, this valve is functioning perfectly. So we've got a mean gradient of 8, got a calculated valve area of 2.4 by VTI and 2.8 by velocity. So those are excellent hemodynamics. Again, single-digit hemodynamics is what you're looking for. And there's really trivial residual PVL. So, this is a winner.
So the things I think about are exactly that, how much PVL we have, and the gradient. And with these superannular valves, we're used to seeing, with core valve, we're used to seeing really acceptable, very, very nice long-term hemodynamics in terms of the residual gradients.
That's absolutely true, and we can even see these gradients drop off a little bit over time as the valve expands or whatever it does with the nitinol, because it does seem like it takes a while for it to really reach its ultimate destination.
Okay.
And while we see good numbers in the lab, they're generally better about a month out.
That's perfect. That's perfect. So what will you do on this patient? I've been taking care of this patient forever, but what do you want me to do in terms of imaging follow-up?
So we routinely check another echo in the morning, just make sure we know what our numbers are, make sure that there aren't any surprises. And we'll also have follow-up in 1 month and then annually thereafter.
Okay, perfect. Well, this was great. I thought the implant, they made it look easy, and I think it was far more complex than what one might have first thought. This is great. We're delighted to have come to you from Honor Health today. Again, our thoughts and prayers are with our colleagues all over the nation during these very critical times. And we thank you for joining us today.